Hello and welcome back to Science of Medicine. In this third part, I want to go over some clinical applications of what we've discussed previously in our pulmonary physiology. Let's take a look at this problem. So let's say a 25-year-old patient is taking an overdose of Xanax. Xanax is a type of medication that can slow the respirations down, and she's only breathing 6 times per minute. Normally you would breathe about 12 times per minute. And also the breathing is more shallow, that is, her tidal volume is not as much. So you examine her, you get an ABG, an arterial blood gas, and you have the final results here. What type of acid-base disorder is present in this case? How do you approach this problem? So if you've done the acid-base interpretation video from before, then you'll know how to go through about this systematically. But if you haven't, this is sort of an introduction, and we're just going to do respiratory issues here. So the first thing that I always look at is the pH. And if the pH is less than 7.40, then I call this an acidosis. If it's greater than 7.40, then I call it an alkalosis. So in this case, the pH is 7.26, which would be for an acidosis. The next thing that I'll do is look at the carbon dioxide, in this case for respiratory. Is it greater than the set point of 40? It is, which is consistent with a respiratory acidosis. Also, if I look at the bicarbonate, a metabolic acidosis is less than 24, so it's not consistent with this. This is in fact a compensatory change. So if I look at this, I've got the 7.26 acidosis, PCO2 is greater than 40, which would imply a respiratory acidosis. And that's what I would expect for a person who's hypoventilating, shallow breathing, less number of breaths per minute. And if you remember, that will stimulate the phrenic nerve to actually, this low PO2 or high PCO2 will stimulate the phrenic nerve to breathe more rapidly and keep it so that you don't die. But let's talk about some other small details, because I could have a respiratory acidosis which occurs relatively rapidly. That's called an acute, or I could have a chronic, something that developed over a longer period of time. And I noticed that this bicarbonate is slightly higher. It's moving in the same direction as the PCO2 to sort of compensate and buffer this pH so that it doesn't change as much. That compensatory change I showed you before, you can look up in a table, and it turns out that for acute, it's a change of 1 millimolar increase in bicarbonate for every 10 millimeters of mercury increase in PCO2. So in this case, that would be consistent with an acute respiratory acidosis, because the chronic would see an increase in the bicarbonate of 3.5 millimolar for every 10 millimeters of mercury of PCO2. So this is an acute respiratory acidosis. Let's try another one. Let's look at a 65-year-old longtime smoker that's seen in the emergency room, feeling kind of short of breath. Respiratory rates are normal. However, you get this arterial blood gas that shows a pH of 7.30, PCO2 of 75 millimeters of mercury, the bicarbonate of 36, and the PO2 of 90 millimeters of mercury. In this case, what kind of acid-base disorder is present? So again, I'm going to do the same thing. I'm going to look at a pH is 7.30. That's an acidosis. Since the PCO2 is greater than 40, that's consistent with a respiratory acidosis. Also, the bicarbonate is greater than 24, so that's not consistent with a metabolic acidosis. So that fits the picture. And now in this case, to distinguish in terms of acute and chronic, I'm going to look at those compensatory changes. A compensatory change for acute is 1 millimolar increase in bicarbonate for every 10 millimeters of mercury increase in PCO2. In this case, I've gone from 40 to 75, and that's not consistent with an acute. But chronic, it is consistent with, because in the chronic state, I would expect a 3.5 millimolar increase in bicarbonate for every 10 millimeter of mercury increase in CO2. I've gone up from 40 to 75, which is a total of 35 millimeters of mercury, 35 millimeters of mercury, and I get 3.5 millimolar bicarbonate change for every 10, gives me an increase in the bicarbonate to 36 millimolar. So this is a chronic respiratory acidosis. What about this one? pH is 7.49, bicarbonate of 22, PCO2 of 30. What type of acid-base disorder is this? So first thing you always do, look at the pH. pH in this case is pH is 7.49 is greater than 7.40. So this is an alkalosis. If I look at the PCO2, it is less than 40, which would imply a respiratory alkalosis. Also, a bicarbonate of 22 would not be consistent with a metabolic alkalosis. It would be consistent more with a metabolic acidosis, so we can't do that. And I can look at the compensatory change and look at a table. In this case, acute respiratory alkalosis will lower the bicarbonate by 2 millimolar for every 10 millimeter of mercury decrease in PCO2. So one of the pieces of information that is available to you as a clinician for respiratory issues is the arterial blood gas. The other thing that we haven't talked too much about is that the PO2. We'll talk about that in some other problems in just a little bit. How about this one? A patient with diabetes mellitus misses several doses of insulin and develops diabetic ketoacidosis. In this condition, the acidity of the blood increases, that is, the pH decreases. How will this affect ventilation, if at all? You have to think about this. Why would ventilation change based on the pH of the blood changing? So you have to remember that as the pH decreases, that means that the carbon dioxide is going to increase. And that's going to lead to an increase in ventilation because one of the sensors in my brain is going to say, oh, I have a decrease in pH, an increase in CO2. I'm going to ventilate that to get it off. And in fact, this was discovered by a physician, and this goes by a certain name called Kussmaul breathing, which is rapid and very deep breathing. And you'll see this in people in diabetic ketoacidosis. How about this one? You live in Memphis, and that's at sea level. You decide to hike in the Rocky Mountains to elevations above 10,000 feet. If the alveolar pressure of oxygen at 10,000 feet is about 73 millimeters of mercury instead of about 104 at sea level, how will your ventilation change initially, and how will this change your level of oxygenation? So remember I said that the low oxygen level in the blood will cause an increase in the ventilation rate. Now, this is really prominent when you get down below 60, but it will happen even at between 60 and 100. And so you'll actually start to breathe a little more rapidly, but will it change your level of oxygenation? No, in this case, you're breathing fine. You're breathing the number of times that you need to. The problem is that the partial pressure of oxygen is lower at the elevated levels. And so consequently now you either have to descend, wear supplemental oxygen, or wait for the production of that 2,3-DPG, that small molecule that will bind to hemoglobin to allow it to offload oxygen more easily. Now let's say a person has asthma, and in asthma their airway can become inflamed. One of the things that we will have patients with asthma do is to use a peak flow meter. It measures their peak expiratory flow rate. And if this peak expiratory flow rate decreases by 10% compared to their best peak expiratory flow rate, in other words, there's no problems with the person's breathing, what percent change in the bronchial radii would you expect, assuming other factors are equal? So I remind you that we modeled flow as laminar in the lungs, and therefore we could use Pissells' law. So Pissells' law shows that that flow is proportional to the radius to the fourth power. Now, if other factors are equal, like pressure changes, viscosity of the air, length of this, you can take a ratio of two different flow rates for two different radii. In one case, you've got a flow rate when the radii are at their best performance, their biggest open, and you get the best flow ever. And the other is when you've had a 10% decrease in the peak expiratory flow rate. So in this case, my Q2 I'm going to put when I'm having some decrease in my peak expiratory flow rate, and I can set this up. I've canceled all these other terms out because, again, they're constant, and they'll cancel when I set the ratio. And now I can take the fourth root of that in order to get the relative change in radii. So this tells me my new radius, when I have this decrease in peak expiratory flow rate, is now 0.974, which is a decrease from 1 and a decrease of 2.6% in terms of that. So I hope that this has been helpful in applying some of the things that we talked about in science of medicine for the pulmonary applications, and I look forward to seeing you again. As always, if you have any comments, you're welcome to do that and leave them there. Hopefully this is helpful to you and you find it at least worthy of your time. I'll see you soon. So in this case, this acute respiratory acidosis, as illustrated from this arterial blood gas, can be corrected by increasing the ventilatory rate. The PO2 is fine at 150, so I don't need to do it.